All right, folks. We're going to move on to the last hour of the afternoon. I apologize for the very short break. Our keynote has to catch a flight, keynote speaker. So we're going to make sure that she can share her expert content with us. So really my pleasure to welcome Dr. Ann Borders today. Dr. Borders is a maternal fetal medicine physician and Ian Bernard Horowitz Endowed Chair of Obstetrics at Endeavor Health at Evanston Hospital in Evanston, Illinois, and clinical professor at the University of Chicago. She's the executive director and obstetric lead for the Illinois Perinatal Quality Collaborative, a collaborative of over 100 birthing hospitals focused on improving outcomes for mothers and newborns. She is funded by PCORI, CDC, as well as the NIH, and her work is focused on addressing inequities in pregnancy outcomes. She serves on the Illinois Department of Public Health Maternal Mortality Review Committee and the State Quality Council, as well as serving as the OB chair for the National Network of Perinatal Quality Collaboratives Executive Committee. And we're thrilled to have her here today to share her experience around engaging maternal providers in this work. So thank you so much, Ann.
Thank you for having me. Hi, everybody. I'm really glad to be here. The work that goes on in Colorado and the quality improvement work is really inspiring. I think you guys have done just really impressive work over time, and the ability to make change happen is something that is not easy. It takes a lot of motivating, a lot of engaging, and a lot of boots on the ground to really improve care. And we talk all the time that lots of people can sit in committees and talk about things. People can put systems changes into place, change policies, but actually changing clinical care, changing the culture of care on your unit so that you actually improve care, that's hard work. And then sustaining it is hard. So I'm going to talk about how we've done that, some of it, in Illinois, or how we've attempted to do it. I will start out just, obviously what you all know, that substance use disorder is a horrible problem that we must all focus on. And I'm going to be talking more on the perspective of understanding the maternal space. So why do we need to think of these mom and baby as a dyad, and why do we really need to be engaging moms, getting them into treatment and care early, and how do we make those changes happen? So talk a little bit about ILPQC, how we try to make change happen. And then our Mothers and Newborns Affected by Opioids initiative, really focused on improving care for families, both a little on the OB side and a little bit of some of the work that our neonatal teams did. And then I'm going to end, this doesn't ask me to touch on some of the birth equity work. And I think that the birth equity work is the foundation of the work we do with opioid use disorder. Everyone's been talking about trauma-informed care and how we must be connecting patients' community. How do we use peer supports? How do we use patient partners with lived experience? And I think that when we're doing this work and trying to do quality improvement work in this space, we have to be thinking about these really important foundations of equitable care. So for us in Illinois, maternal deaths due to opioids really need our urgent attention. So I know in the neonatal space, and we're thinking about plans of safe care. I sit on a plans of safe care committee for Illinois, and my job is basically to raise my hand and talk about how it's not just plans of safe care for baby, it's plans of safe care for mom, and that the leading cause of maternal death in Illinois, by far, it's not even close, is overdose. When you look at causes of maternal death, over a third, and these are the pregnancy-related deaths. That's not even all the pregnancy-associated deaths that don't get deemed pregnancy-related. You would double that if you just looked at pregnancy-associated deaths related to overdose. So over a third of our maternal deaths in Illinois that are pregnancy-related are overdose, and this has been a dramatically increasing problem. So as we look to partnering on how do we make a difference for these families, for these moms, we have to start early. We start prenatally, but we think about that delivery admission. We think about partnering with neonatology colleagues. We think about partnering with our pediatric colleagues. We think about partnering with our social work colleagues. It takes everyone to keep mom and baby safe. And so I'm going to start out talking about what it takes to keep mom safe. And why do we need to improve care? Women are losing their lives to OUD. And these are just two faces These are just obituary pictures in the paper for moms, Madeline and Anaya. And these were their pictures that were with their obituaries of them with their babies. These were moms that lost their life to overdose. And addiction does not discriminate by race, ethnicity, insurance status, sociodemographics. One of the patients that I have had who had some of the most challenging addiction issues I've worked with was one of the more wealthy patients that I've ever worked with. So it really is, it touches everyone. And it's not just an urban issue. It's not just a rural issue. It hits everywhere. And we have to convince our clinical teams that OUD is a life-threatening medical condition and that screening and linking our pregnant patients with OUD to treatment and services reduces overdose deaths, improves pregnancy outcomes, and increases the number of moms and babies who are able to stay together and have healthy lives together. So we really have to see OUD as a life-threatening medical condition. And I have spent a lot of time going around and giving talks to hospitals around the state, big hospitals, small hospitals. And I think that issue is the number one thing that has to be communicated all the time, that OUD is a life-threatening medical condition and that there's treatment available. And if you can get, I like to get little nuggets that people can hang on to. And I think it's a really important for clinical teams who care for pregnant postpartum patients and families dealing with addiction, that it is a life-threatening medical condition and that we have treatment available. This is data from Massachusetts, from our friend right here. Navita's gonna find that very familiar because I'm referencing her here. This is her work, but the treatment works. And I use this slide a lot on Davita, so you probably talked about a lot when you don't realize it from me. That we see decreased overdose when we put patients on medications for OUD. The orange are overdose events on patients who are in treatment, and the gray are overdose events not on treatment. So I took two things away from looking at this data of Davita's, that MOUD saves lives across pregnancy and postpartum, and that postpartum is a really risky time for all moms with opioid use disorder. So look at that postpartum period, see those gray lines go up. And so that's a time when we really have to pay attention. That's why it takes everyone. It takes our pediatric friends, our neonatology friends, our OB friends, our emergency department friends. People have to remember that this is a life-threatening illness. And I tell our clinical teams all the time that when you have a patient with opioid use disorder on your labor and delivery unit or in your NICU, that person is probably the highest risk patient of a maternal death of anyone on your unit. So you wouldn't walk away from someone who is in DKA and say, they'll be fine. They shouldn't have had so many sweets. I'm going to give them a phone number and they'll probably get some insulin sometime next week, right? That person with severe preeclampsia, right? They'll be fine. They'll probably get some care somewhere. The patient with OUD is a leading cause of maternal death. They are the most life-threatening illness. They're not dying in the operating room, but they may die a month from now on their bathroom floor of an overdose if they don't get the care that they need. And so convincing people that we have to provide optimal care for patients, for families, and take care of the dyad, that's how we change lives. So this is our ILPQC collaborative. It's very similar to Colorado. We're a collaborative of doctors, nurses, patients, families, public health leaders, and we're really working to reduce disparities and improve health outcomes. And we started our MNO, we called it the Mothers and Newborns Affected by Opioids Initiative. And we started in 2018. And our goal was to improve optimal OUD care for pregnant persons across the 92 participating hospitals. And we finished it right before COVID hit, or at least I wouldn't say finished. We started moving into sustainability. But those 2 years before COVID, we're really focused on this work. And from the beginning, we tried to focus on both. We very specifically named it mothers and newborns. We had an OB teams and neonatal teams, and we needed to work on it from both sides. So we make change happen through ILPQC. The SIM is all PQCs by engaging hospitals to create an environment of improvement, motivating hospitals, being cheerleaders, to facilitate change at their hospital, that hard work of making change happen. And then we support hospitals through collaborative learning, rapid response data, and QI support to achieve initiative goals and to equitably improve outcomes and reduce disparities. So we also track data by race, ethnicity, and insurance status. We just have been celebrating this. In November, we'll celebrate 13 years of ILPQC, really working together, engaging patients and communities, and making change happen. And that's kind of our North Star of what we're trying to accomplish. I just realized I don't have the most recent updated one that has through 2025 on it. And that if I had 2025 on here, we've started promoting a perinatal mental health initiative, which really takes on the work that we did with mothers and newborns affected by opioids and extends it into all perinatal mental health, really focusing on depression and anxiety screening and treatment and follow-up. So these are the different projects we've done, and I'm just going to touch base on the two that are highlighted red, the mothers and newborns affected by opioids and the birth equity work. The orange is our neonatal initiatives. I'm going to tell a quick story. This is an actual story from one of the cases that I reviewed on maternal mortality review committee. We review all the maternal deaths. So I see these stories over and over and over again. And that's what really motivates, I think, to do this work when you're reviewing cases of moms who've lost their lives. So Sarah was a woman in her 30s with a history of substance use disorder. She was on methadone for her substance use disorder for several years until she moved to Illinois from another state during her first trimester. And she did not get it restarted when she moved to Illinois. She started prenatal care in Illinois during her second trimester, and during one visit was given information to contact a nearby substance use treatment facility. But throughout the rest of her pregnancy, when she had regular prenatal care visits, the prenatal care provider did not have any further discussion with her about her substance use treatment. During her third trimester, she had a positive urine drug screening, but no additional treatment information was provided. So she was going in, she was getting her blood pressure checked, she was peeing in a cup. She was doing all the stuff she was supposed to get for prenatal care. Maybe somewhere on a problem list, someone had written down substance use disorder history, and that was pretty much at the extent of it. After delivery, she had another positive urine drug test, and her baby was taken into Illinois Department of Children and Family Services care. So all those prenatal care visits, no getting her under treatment, no getting her back under recovery. At discharge from her delivery hospitalization, Sarah was not connected with any substance use disorder treatment or recovery services. In the weeks that follow, Sarah had multiple emergency department visits for heart problems, where she disclosed to emergency providers at each of those visits that she had substance use disorder. She did not receive any referrals for substance use treatment or outpatient cardiology, and no communication occurred between the emergency room providers who saw her multiple times and her OB provider. 2 months after delivery, she passed away from heart failure related to her substance use. So what could we learn from Sarah's death? And this is basically what we do in Maternal Mortality Review Committee. And maybe some of you are on the committee here in Colorado. We review cases, we talk about the causes, we identify recommendations of how we can do better. And those are the recommendations that we then have to take out into the field, and perinatal quality collaboratives and folks like all of you are then charged with how do we learn from these deaths and how do we do better to improve care? And it really matters. It's a life and death situation that we improve care, right? That we get systems in place and workflows in place to improve care for patients. And patients with mental health conditions and patients with substance use disorder, it can be hard work, right? Trying to figure out the best way to care for people. But those workflows, those systems are so important because they save lives. So what can we learn from Sarah's death? She disclosed her substance use disorder in many different healthcare settings, including during prenatal care, during her delivery admission, multiple emergency department visits, but not receive a warm handoff to treatment or recovery services. And just as someone who came into pregnancy in treatment, lost her treatment provider, and then just never got re-hooked up. Community-based support services are really needed for women with substance use disorder to ensure they receive necessary referrals, care coordination, and navigation for the needed services, treatment, and follow-up, right? How great would it have been if she'd been connected to peer support or a patient navigator or a case manager or a care coordinator, someone who had said, hey, let me take your hand and figure out how to help you get connected back onto methadone or back into treatment. Clinical professionals interacting with women during pregnancy, postpartum should have knowledge of community-based resources and support connecting patients to them. We can't give patients a phone number. They should see patients with SUD in pregnancy and postpartum as high risk for morbidity and mortality, and linkage to treatment with warm handoffs as urgent and necessary care for a life-threatening illness. I think that's one of the most important things we talk about. Linkage to treatment with warm handoffs or urgent and necessary care for life-threatening illness. This patient didn't get standard of care and she died. A warm handoff and navigation to treatment, that is standard of care. It's just as if someone had severe preeclampsia and no one started her on magnesium or gave her blood pressure medication, or she was in DKA and no one started her on insulin. When babies are removed by DCFS, we see increases in stress, mental health concerns, and relapse among parents. It's such a common story in these maternal overdose deaths. We are working currently in Illinois to decriminalize SUD in pregnancy, this whole issue of substance use disorder is not neglect, neglect is neglect. And really improving coordinated plans of safe care, which we've been talking about all day today, which is why I've been taking so many pictures and learning from all of you. In Illinois, we now have a central hotline to call 24/7 to get patients started on SUD treatment and provide a care coordinator to help navigate patients to follow-up and resources. And our biggest challenge now is getting enough OB providers, pediatric providers, and emergency room providers to know to call that number when they identify a patient who needs treatment. Okay. I think that was the most important thing that I did today, was share that story and share why it's so important. And hopefully I convinced some of you when you go home to think about this. So we had to go back to the beginning when we were talking to clinical teams, because they really, the way that they were thinking about it, and we were a year into our initiative before we realized we have to start back at the drawing board. We have to re-educate people, because what we realized is that when people found someone who was screen positive, they still were thinking, call neonatology to let them know the baby's at risk, and call social work so someone can come here and call DCFS. And they still weren't seeing the mom as a person at risk, that everyone's head needs to swivel to mom and say, this mom has a life-threatening illness that needs treatment. So we went back to the beginning. We made posters. We put them all over the state of Illinois. We made magnets. We talked about it constantly. And this was our key message, that opiate use disorder is an urgent obstetric issue. It's a life-threatening chronic disease with life-saving treatment available. There's key steps clinical providers must take prenatally during the delivery admission and postpartum to care for women with opiate use disorder. And linking moms to MOUD and recovery services reduces overdose deaths, improves pregnancy outcomes, and increases the number of women who can parent their babies. Optimal care for all pregnant women. So what does optimal OB care look like? Screen every pregnant patient for OUD with a validated screening tool, assess readiness for treatment, link to MOUD and recovery treatment services, provide naloxone, warm handoffs, and patient education, and then reduce stigma and promote empathy across your clinical team. One of the most important things, if we don't have that, patients will not come back, so the rest of it doesn't matter. So lessons learned, systems for optimal OUD care. Given the high risk of maternal death for OUD, we need systems in place to make sure that the optimal OUD OB care is provided every patient every time. So it doesn't matter if it's a small hospital and a patient walking into a NICU, that pediatric team needs to understand this, or a big academic emergency department. We need to make sure that we have these workflows set up. We developed M&O OB folders so that they were folders, they were green. They went into clinics and outpatient spaces and labor and delivery and emergency rooms all over Illinois. On one side, there were workflows for providers, and then on the other, there was education materials and numbers to call on how to get help for patients. We did order sets and lots of prenatal care team conferences to make sure that we could really give patients the care that they needed. We set up universal screening. The goal of screening is to identify patients with life-threatening illness to start treatment early in pregnancy or before delivery discharge, and then support instead of surveillance, and life-saving treatment instead of criminalization. These were the M&O folders. These were actually created by one of our clinical teams. One of the hospitals built these folders, and then every hospital in Illinois copied them. So they were using them and they gave this amazing presentation about it. And then all the hospitals were like, we want this. So we made them for everybody. And then on the one side, it was patient education materials. On the other, it was clinical team. We had them all electronically. And then it turned out that if you had them electronically, the providers in the clinic, or they just wouldn't think to go get them. But if someone had a stack of 10 of these green folders on their labor and delivery desk or in the ER room, or I still go to sometimes to outpatient spaces and I'll like be back by the computer. I'm like, oh my gosh, a stack of like M&O folders. And we made them all green. So everyone around the state knew what they were. And people would think, oh, I have a patient I just identified with OUD. Where are those green folders? And they would go grab them and they would pull the materials out, be like, this is what I need to do. Here's the number. Here's the Illinois Doc Assist, which is like your guys's promise. So it's just a way of getting resources. We made checklists of how to manage patients. OB providers told us over and over again they weren't trained to manage patients with OUD. And so we tried to break it down and make it very easy what they needed to do. The nurses said, we need a workflow. So we made a workflow during the delivery admission for the labor and delivery nurse, steps they needed to make sure that they took, and then for the postpartum delivery discharge nursing tasks to make sure patients were getting the clinical steps they needed to reduce risk of maternal death. We made patient education materials, and we actually used all patients with lived experience. We had them in groups in 5 different cities with moms and families who'd had babies in the NICU with NAS. And they came together and they worked on these. They picked out all the pictures, they picked out the language, and they developed these resources. So I like this one, what you need to know, be with your baby, you are the treatment. And that's all came from these groups. So you had these really awesome treatment and education materials for moms. We really focused a ton on eat, sleep, console and non-pharmacologic care in the hospital. It's a big push on our neonatal side. We did M&O education for all OBs and nurses in the state. We had a big push around trauma-informed care, and we recorded this video with a patient being interviewed, which was really powerful. It was called our Words Mattery module. A lot of people use that for training. We recorded provider and RNE modules, like what you need to know and what you need to do to provide optimal care from both an OB and a nursing perspective. We had an education campaign where we made all these posters and magnets and distributed them all over the state. And they said, like, save a mother's life, what you need to know to save a mother's life. And we just really kept talking about that moms are dying left and right, and we all need to do something. And we created urgency. We helped develop a ad campaign for this Help Is Here helpline. The helpline is a 24/7 line where people can call, and an addiction medicine physician will help get a patient connected through telehealth to start on MOUD. And then they have a care coordinator that manages to get them transportation, all the care they need to get into treatment, and then to get into follow-up care. And this has been one of the more incredible programs that we've had in Illinois. It's really successful and one of the best public health things I've seen happen in our state. We have the DOPP program, which helps give out free Narcan kits. And then we really realized that OB providers literally didn't know how to write a prescription for Narcan. So we made all these posters and put them everywhere with literally wrote out how to write a prescription for Narcan. So it's just like those little things that you don't realize. And then this is one of our patient partners who's worked with us for a really long time. And she was, that's one of her granddaughters that she's hugging. And she is someone who had 5 babies that were in the DCFS system and ended up going back and getting into treatment, getting her high school degree, getting her college degree, getting graduate school degree, and has been working with ILPQC for a really, really long time. These are some of the posters we made, what every OB provider needs to know to save a mother's life. So you can see we had a real theme, save a mother's life. We had education resources for our neonatal teams. A lot of these were around mothers are the best treatment for infants with NAS, really promoting what it means to do eat, sleep, console, and non-pharmacologic care. And then really a lot of focus on discharge and plans of safe care and how to make it about both mom and baby. And then also around the support for breastfeeding. So a lot of great work. We also did these really cool videos around engaging moms in non-pharmacologic care, and a really great video on Eat, Sleep, and Console. This is one of my favorite things that we did. This was actually a mom who started working with the Florida Perinatal Quality Collaborative, and then worked with us as well to make this story. I usually like to share it, but we don't have time today. But I would really encourage folks to scan and pull her story up. It's 10 minutes. And if you have time on the way home today to listen to Angel's story, it is incredibly important story. And I think it helps us think why patients receive, with so much stigma, it's really hard to get into care, and that when we are treated with nurses, providers, social workers who reach out with empathy, support, non-judgment, and a belief that you can get better, that's when patients move into treatment and recovery. And for her, having Narcan and having access to Narcan made all the difference in the world. And so we use this story a lot when we're trying to encourage and convince people to use Narcan and hand out Narcan to patients. So really briefly, I'm going to talk a little bit about the data and what we were able to accomplish with the initiative. So we had 101 birthing hospitals in Illinois who started. 91 hospitals participated in the data and submitting data. They basically submitted data on all patients identified with opioid use disorder over the project. And we had about 2,500 patients with OUD who delivered during that project. And then we did a random sample of all patients who delivered. We have 28,000 patients in that sample. And those were just random sample of all patients. We did from every hospital every month. They sent us a random sample and looked to see whether patients were screened for substance use disorder prenatally and whether they were screened during the delivery admission. And then if they were screened positive, were they linked to treatment, and were they linked to recovery follow-up, and were they provided Narcan? So first were our systems changes. This was really about making systems change happen. These are our structure measures, and we move red, you haven't started working on it, yellow, we're working on it, and green, we have it in place. So 100% of teams got validated screening tools in place on labor and delivery. 80% of teams got validated screening tools in place prenatally. 93% of teams had expert protocol and algorithms in place on labor and delivery to start treatment and counsel. 93% of teams mapped community resources for women with OUD. 93% of teams implemented an OUD clinical care checklist, and 93% of teams standardized OUD patient education. So really successful. The left-hand side is prenatal screening for substance use disorder during pregnancy. The green is screening with a validated screening tool. The yellow is like a one, just asking if someone was using, and the red was no screening at all. And we really wanted to move into the green screening with a validated tool. We use the 5 Ps, and then you can see our sustainability. And then what really changed was our labor and delivery screening, and that's where we saw a lot of screening, a lot of ability to link moms into treatment before they went home from their delivery admission. So we did a ton of work during that delivery admission of getting patients linked to treatment and follow-up. When we started, patients with an OUD diagnosis, a known OUD diagnosis, were only linked to treatment during pregnancy or the delivery admission 41% of the time. And then by the end of our initiative, we're up to 88% of the time patients who are identified with opioid use disorder during pregnancy or the delivery admission were linked to treatment before discharge. So really amazing. The blue is linked to treatment. The red is linked to recovery treatment follow-up. So having an appointment scheduled with behavioral health before delivery discharge. And that had to be a warm handoff already scheduled. This was our naloxone time. This was so hard. When we started, only 2% of patients with a known OUD diagnosis, anyone had ever talked to them about Narcan during the pregnancy or during the delivery admission. Not even a conversation about it. Nothing documented, as if Narcan or naloxone risk reduction strategies did not exist. We spent a ton of time talking about it. It took so long to get people comfortable, and we've really started to make some difference. We also saw big inequities, disparities in who got linked to treatment. And this was really interesting when we started our work. It told you 41% of patients were linked to treatment when we started with known OUD. But what I didn't say is that for Black patients, they were getting linked to treatment half the rate of white patients. So the orange is Black patients. They were getting linked to treatment only 23% of the time. Our white patients were getting linked 48% of the time. So no one was getting linked effectively, but our Black patients were getting linked at such rates that were just absolutely astounding. And so what we did over time by stratifying this data and sharing this data, people were really working on it. They're aware of it. And we said every patient, every time, every patient, every time. And by the end of the initiative, when we were in sustainability, we hit that mark of over 70% of patients linked to treatment, which was our goal. I'm going to just really quickly give you a few of the neonatal so I can wrap up. These were our neonatal structure measures, prenatal consult protocols in place, non-pharmacological protocols in place, farm protocol, and then coordinated discharge protocols. So again, really working to move those systems into place. We saw a reduction in newborns receiving pharmacologic treatment as teams implemented Eat, Sleep, Console, from 41% down to 33%. And then reduction in average days of farm treatment from 17 down to 9. And then this was right before COVID. And then we also saw a reduction. We saw disparities in breastfeeding. So the blue is Black patients, the orange is non-Hispanic white. And you can see there was a big disparity in who was breastfeeding for patients who were opioid exposed. And they were able to eliminate that disparity by the end of the initiative. Here's another one of our moms who participated in this campaign with us, Kelsey, in recovery since 2019. And just some really beautiful pictures of these moms and babies. So very briefly, we felt that when we were doing this initiative, we had to start working on the equity issues because we saw this data that was so stark around who was getting linked to treatment and why. We were able to really have these conversations with our teams, and we started working on those equity strategies, stratifying data, linking patients to social determinants of health, engaging patients and community members to do QI input like we did with our patient education resources, implicit bias and respectful care training, and then really leaning into improving respectful care. This was our SUH screening. The blue is screening patients for SUH during the delivery admission, but we found that even if patients screened positive, they weren't getting linked to resources. The orange is for patients who screened positive for SUH needs. Did we have documentation they were linked to resources? So you can really see a difference over time where these are a random sample of patients during delivery admission, really changing who is getting screened for social determinants of health and who is getting linked to treatment. We did a lot of work helping people map and get partnerships with community resource and able to do those linkages. Doesn't just happen. We worked a ton with respectful care. If you're interested in it, you can look at our ILPQC birth equity toolkit. We have a lot of respectful care practices we worked on with our patients. I think it really came down to what we've been talking about all day, the shared decision-making, that recognizing patients as the experts of their own experience so that we can improve active listening and empowering patients to make choices for accessible, non-judgmental communication. We worked on strategies to continue to engage patient and community partners for input, getting patient partners on our QI teams, and really moving from just having patient partners on your QI team to really having discussions with patients, with our docs and nurses on our labor and delivery units to get input on what we can do better to provide better respectful care. And we've made a huge amount of progress with this. We started something called Respectful Care Breakfast because we do a lot of respectful care. We do a lot of breakfasts in hospitals. Doctors and nurses come to breakfast. So we invited patients who delivered in the last year to come for breakfast and talk about what do you think respectful care is? What are examples when you received really great examples of respectful care during your pregnancy or delivery? And what are examples where we could have done better with respectful care? Those were the 3 questions. We started doing these respectful care breakfasts. They kind of caught on across the state. We've now had 144 respectful care breakfasts completed by 62 hospitals across Illinois. Now most hospitals are doing them about twice a year. And the patients really love them. This was patient feedback. Really appreciate the opportunity to discuss my experiences and how open the staff were for feedback. I feel like caregivers genuinely cared for the feedback and wanted to know how they could improve. We did this because we were working with patient partners, and we now have 88 patient partners with birthing hospitals in Illinois. But they were like talking to the QI teams, like people who already kind of like bought in with the Kool-Aid. So they're helping the QI teams do better. But did you have labor and delivery docs and nurses who are like still not getting what respectful care is? We talk about respectful care and they're like, oh, I provide respectful care. That's why I'm a doctor. That's why I'm a nurse. They weren't really getting it. And so we needed patients to be in front of docs and nurses who are at the bedside in order to change culture. So how do you change culture in a unit? You get patients in front of them. So these respectful care breakfasts are really meant to change culture. So this is last, how do we build infrastructure for sustainable equity strategies, stratify data, engage community partners, and establish ongoing patient community input. We think there's an urgent need to take action and improve optimal OB care for patients with SUD, OUD. We have to identify and address disparities and implement equitable QI. Patients experience a respectful care and reduction of stigma matters to improve care and outcomes. Listening to patients and communities tell us what changes are needed, and we can build collaboratives where you can find them to help make change happen faster where you work, and consider how you can take action. And thank you guys for having me.
Thank you so much, Anne. Before Anne hops on her Uber to go to the airport, I think we have time for 1 or 2 questions. I'll get us started. I was so impressed by the fact that both the data and the efforts that the MNO initiative that you all led included both the maternal and the infant side, both in terms of the interventions as well as the data. Now, for each of the hospitals that were engaged in that work, were they dyadic? Were the care teams, in fact, integrated? Because that's what we're trying to kind of really hone in on.
I think it really depended. We definitely had people, there was OB teams and neonatal, there's like an MNO OB team and MNO neonatal team. But I would say in most places, they were either, in some of our little places, they were completely overlapped. It was one team. And then in other teams, it was an OB team and a neonatal team, but they had like members on each other's team, so they know what each other are doing. So there is communication, but we had a MNO OB webinar. So every month there would be an OB webinar and there would be a neonatal webinar for MNO. So we were working along together and we were informing and educating, and we'd have our meetings in person together. So we were always knowing what each other were doing, like our big in-person meetings were together, but then all of our monthly webinars were separate. So people kind of, I think that they really work together. And there were a lot of places that were, small, and it's like one nurse who does everything,
Oh, I was just curious of the moms.
Like, we have folks that are on.
With the moms who you offered therapies, treatment, recovery programs, were most of them receptive to going into programs?
It's really interesting, and I'm sure Davida could talk about this a lot. Our patients were really receptive to going into treatment. I mean, not every person is. And the thing is, it's usually an ongoing conversation. Patients are more motivated, I think, during pregnancy, because especially for us in Illinois, if someone's in treatment, DCFS doesn't even open a case. So if someone's in retreatment, in recovery, so they're highly motivated, I think, to get into treatment, but not just because of DCF, because you're at a point where you're having a baby and you want to be in treatment. And we could show, and we have data I didn't show here, that our patients who got into treatment had lower rates of preterm birth. They had better pregnancy outcomes in treatment, right? So, and even if you control for people having the same number of prenatal visits, it wasn't that this in treatment, we're getting better prenatal care. We could control for that and we would still see that patients had better outcomes. So we talked a lot about what does treatment do? It reduces the risk of death for you. It improves your pregnancy outcomes for you and your baby, and it improves the chance of keeping your family together. And so there's a lot of motivation for patients to get into treatment.
All right. Thank you so much, Anne. We really appreciate it.
Thanks, guys, for having me. I really appreciated being here. I learned a lot.
Yeah. I'll see you next time.
Absolutely.
Safe travels.